This lecture is going to cover Chapter 8, Pharmacodynamics in your Practical Pharmacology for the Surgical Technologist textbook. And pharmacodynamics basically means what the drug does to the body. So we're going to talk about what the drug does to the body. So when we talk about pharmacodynamics, the book indicates that it is used to describe the way a drug interacts with the body. And here we're talking about how it interacts with a cell membrane, organelles inside the cell, the tissues, the organs, or the entire body. And so that has to do with the physiology or the functioning of the body. So it only makes sense, like if the body is functioning at its peak performance, then pharmacodynamics is going to be a lot easier to predict and understand how drugs are going to impact the tissues and the organs and the cells. But if the body is not, then that is when things can become a little bit more tricky. And there's numerous factors that can either speed up or enhance the movement of drugs through the body, and conversely, there are a multitude of factors that can impede the movement. Now, this is the link between pharmacodynamics and pharmacokinetics. So remember, you talked about pharmacokinetics or learned about pharmacokinetics in Chapter 7. Remember, pharmacokinetics is the way the body processes a drug. Now, pharmacodynamics is the way the drug interacts with the body and the effect that it has on the body. So there are three main aspects of pharmacodynamics that we're going to talk about, and those three aspects are the onset of action of the drug, the peak effect, and the duration of action. And then you can see here on this diagram that we have two other factors here that at the very beginning, we have drug administration, and at the very end, we have the termination of action. So the onset of the drug is the time between giving the drug and the effect, seeing the effect of it in the body. So I'm going to use for the purpose of describing these three aspects of pharmacodynamics, ibuprofen. So when you take ibuprofen, the onset of action, according to PubMed, is approximately 24.2 minutes in the average person, okay, in the average person. So I take a pill because my knee is hurting. Now, how long does it take before my knee starts to feel better? The time that lapses between when I take the ibuprofen and I start to notice that my knee is feeling better, that time that has elapsed is considered the onset of action. So let's move on to the peak effect. The peak effect is the time that elapses when the drug is most effective, okay? So the peak effect, I take the ibuprofen and my knee is starting to feel a little bit better at the onset of action. But when is it feeling the best? Okay, when it's feeling the best, that signifies the peak effect of my ibuprofen. And that is approximately 1 to 2 hours after I take the ibuprofen. That would be the peak effect. Now, The duration of action is the time that elapses from the onset of action. So when my knee starts feeling a little bit better to the termination of action. All right, I can't feel its effects anymore. That is referred to as the duration of action. So I take my ibuprofen, I start to feel its effects, and now I don't feel any effects at all. My knee is feeling just the same as it was before I even took the ibuprofen. That's the duration of action, and that is approximately 4 to 6 hours for ibuprofen. Now, let's talk a little bit about medication actions. Medication actions pertains to why a drug is given. Why do we give drugs? Why are they prescribed? Why do we take them? Because there is some sort of desired effect, okay, or reaction that our body has from the drug that we take, okay? Drugs can change the physical components, constituents of the cell that it is targeting, okay? They can change the function of the cell, but they can't initiate new cell functions, okay? But they can facilitate a change in the function. But they can't make cells do new things that they've never done before, okay? So when we have drugs that are absorbed from the blood into the target cell, they do so by the same mechanism that allowed them to be taken into the blood for distribution, okay? And those two different types of processes we've talked about several times in our time together, and those are active and passive transport mechanisms. So remember, active transport mechanisms are those functions that require the cell to use energy, that very valuable ATP or adenosine triphosphate. Remember, it's like pushing the rock up the hill. That requires a lot more energy from me than if I was going to be just pushing the rock down the hill, right? You give it a little shove and away it goes, right? Not a lot, really no effort once I give it a little shove, which would be passive transport, right? Like processes of diffusion, like osmosis, and those types of things. Okay, so that's how drugs move out of the bloodstream and into the cells. So there are 4 methods by which drugs are thought to elicit responses, and the book refers to these as drug theories. So we're going to talk about 4 drug theories, and those are drug receptor interactions, drug enzyme interactions, non-specific responses, and chemical interactions. So let's first talk about drug receptor interactions. So we know that cells have receptors on them, these special proteins that are embedded within the cell membrane, okay? And so these receptor sites sometimes can allow a drug to attach to that specific receptor. It's like a lock and key. Remember when we talked about antibodies and how there was that lock and key concept with antibodies and antigens. And so this is really the same thing. When pharmaceutical companies manufacture drugs or design drugs, a lot of times they're designed with a specific target receptor in mind, and they say that the drug has a certain affinity or attraction to a certain target cell. Now, this may mean that the drug attaches to the receptor site on the cell membrane and elicits some sort of change in function. Or that might mean that it changes that site and then the chemical is allowed to enter the cell and interact with the organelles or within the cytoplasm of the cell to elicit that response. Okay, so that's drug receptor interaction. Now, drug enzyme interaction, remember enzymes are like the catalysts that elicit changes. And so some drugs actually interact with the enzyme, and they cause one or another reaction, and those are to speed up the drug itself, or to speed up the enzyme, or to inhibit the action of the enzyme. So it can cause the enzyme to act faster, or for the cell to produce more of the enzyme, or it can actually inhibit the enzyme altogether. And so I looked up a couple examples for you, and when an enzyme is inhibited by a drug, that drug is called an enzyme inhibitor. Who would have thought? An example is Relenza. Relenza is given to treat the flu, the influenza virus, and what Relenza does is it inhibits a viral enzyme that allows for the release of the virons, which then spread the virus. So inhibiting the production of that enzyme actually stops the spread of the virus throughout the body. Remember, viruses invade cells. So that's pretty cool. Another example of an inhibitor is penicillin. The antibiotic penicillin actually binds to the bacteria and it inhibits the enzyme that would initiate the process that the bacteria uses to strengthen the cell wall. And by inhibiting this enzyme, it causes the cell wall to become thin and weak, and then it eventually ruptures or lyses. An example of a drug that speeds up the action of an enzyme is called an inducer. And an example of an inducer would be tobacco, interestingly. Okay, so now let's talk about non-specific responses. Drugs that elicit non-specific responses really do not have a specific target receptor in mind, like drug receptor interactions. Remember how I said that the drug is targeted towards a specific cell or receptor on a cell. And so non-specific responses are evoked in a variety of places throughout the body, right? So there's not a specific target cell, and a good example of this would be ibuprofen. And then lastly, chemical interactions. Chemical interactions has to do with the potential of some drugs to result in a simple chemical interaction. So here's an example. Sodium bicarbonate, we've heard of that before. It's basically a baking soda, And we know that that has a very high pH, right? It's a base, it's very alkaline. And we also know that hydrochloric acid has a very low pH. It's extremely acidic. And so the two will buffer one another. And we learned about those chemical reactions in anatomy and physiology. Now, moving on to drug interactions. When two or more drugs are combined, they interact with each other, and many times more than one drug is given simultaneously to produce a desired result. So there are a variety of drug combinations that produce desired interactions, and those include synergists, agonists, antagonists, and additives. And, unfortunately, some drugs are prescribed and they produce harmful responses, and this is an unintentional response. And so that's why it's really important for healthcare providers to have current and accurate and complete information about the patient's prescribed drugs. I can remember, not that I want to harp on the VA, but my grandmother was a Navy veteran, and we were taking her to the VA in Tucson, and every single time she went, she saw a different provider who would put her on a different medication or suggest a different vitamin or some sort of supplement, and she kind of had this hodgepodge of drugs that she was taking, but nobody had really sat down and looked at all of the drugs collectively. And so it's really important that, there are pluses and minuses of technology and kind of storing all of our information in a cloud somewhere or in a database somewhere. But I do think that there is some value in these systems being able to talk to each other and give alerts. And so there are special software systems that they are using now that can alert a healthcare provider if there could be some potential harm from a drug interaction. So the first interaction I mentioned was a synergistic interaction. And a synergist is a drug that works together with one or more other drugs, and that is going to produce an enhanced effect, or what they call a cumulative effect. And this effect is even going to be bigger and better and badder than each of the drugs individually. The book gives an example of Tylenol being combined with codeine. Tylenol is an analgesic, and it also helps to reduce fever, but when it's combined with codeine, it also can generate a greater analgesic effect than either of the drugs used separately. Secondly, we're going to talk about agonist. And agonist is very similar to synergist. Synergists are agonists, and an agonist is a drug that simulates or prolongs the action of another drug or naturally occurring substance in the body, but doesn't necessarily have an action on its own. Okay, the book gives an example of hyaluronidase, which is an enzyme, And oftentimes it is added to local anesthetics such as xylocaine, which is the trade name for lidocaine. And what hyaluronidase does is it helps to promote the diffusion of the local anesthetic into the tissues. So better diffusion means they're going to get a better effect of the drug. There's going to be a faster onset, right? And it's going to give better numbing action because it's going to be evenly distributed throughout the tissues. So that's a really good example of an agonist. Now there are three different categories of agonists. There's strong ones, weak ones, and partial ones. Now, I was kind of doing some research about this, and I found that opioids some of them fit into all three of these categories, or all of them rather. And so I'll just use that as we kind of work through this. So strong agonists are going to be the ones that produce the greatest effect, but they don't have to occupy all available receptors on the cell membrane. In fact, they don't have to occupy very many at all to get this real, big bang for their buck sort of thing. And some examples of strong agonists are fentanyl, morphine, and heroin. Now, weak agonists basically produce the same effect as strong agonists, but they have to occupy a greater percentage of the cell membrane's receptors. And an example of a weak agonist would be codeine. And then lastly, partial agonists are really only going to get a partial binding to the receptors on the cell membrane, and they may be binding to all available receptors, but they're only going to give a weak effect. And an example of an opioid that is a partial agonist, which there weren't any that really jumped out at me as kind of common or well-known types of opioids, buprenorphine is, or buprenorphine, I guess, which I haven't heard of before. So would be considered a partial agonist. So let's move on to talking about antagonists. So if an agonist is going to simulate or prolong the action of another drug or naturally occurring substance in the body, an antagonist is going to do the opposite. An antagonist prevents or reverses the effect of another drug or naturally occurring substance in the body. A good example of this would be the drug Narcan. Narcan is used to reverse the sedative and hypotensive effects of various narcotics that are given and oftentimes intraoperatively. So antagonists don't generally produce an effect on their own. They are specifically used to block or reverse an effect of another drug. And there are 5 different types of or categories of antagonists. And the first one is competitive antagonism, which sounds just like the word suggests, that the antagonist is going to be competing to bind on those target receptors that would normally be occupied by the initial drug. So remember, if we have a drug that has a target receptor then this competitive antagonist is going to swoop in and bind at that site so that the drug can't bind there. All right. But what's interesting about competitive antagonism is that if really high doses of the drug have been given or more of the drug is given, then they could overpower the effects of this antagonist, of a competitive antagonist, right? If there's more of the initial drug, then there's a higher probability that there's more molecules there. They're going to bind to those sites before the antagonist can. So secondly is the non-competitive antagonism. And a non-competitive antagonist is going to bind to a receptor site that would not normally be occupied by the initial drug. And this is going to cause a change in the initial drug's receptor site, and it's going to render it unrecognizable and unusable so that initial drug can't bind there. And the word that they use to describe this type of antagonist is insurmountable. Another insurmountable type of antagonism is called irreversible antagonism. Another name for irreversible antagonism, according to the text, is non-equilibrium competitive antagonism, which is really similar to competitive antagonism. The only difference is competitive antagonism is surmountable. Remember, it can be overcome with high levels of the drug, of the initial drug, high doses of the initial drug. With irreversible antagonism, the effect is permanent. So again, we refer to that as insurmountable. The fourth type of antagonist is called a physiological antagonist, and that occurs when two drugs are given that cancel out the effects of each other. Okay, they cancel out the effects of each other. It's like a +2 and a -2. They cancel each other out and result in 0. And the last one is antagonism by neutralization. And this occurs when two drugs bind together, so they actually combine with one another, and in that process, inactivate one another. So additives are substances that are combined with an initial drug for a variety of reasons. And additives can be a variety of different substances that can be used to dilute a drug, reconstitute it, activate it, preserve it, give it flavor, or alter the pH of the initial drug. And there is a term that the text uses called excipient. An excipient is used to describe an additive that doesn't affect the performance of the drug whatsoever. An example of an additive could be adding hydrochloric acid to Narcan. Now, Narcan is a very strong base, and if it is not mixed with hydrochloric acid, then it can be very irritating to the tissues. So Narcan and hydrochloric acid will buffer one another, and that will lead to a decrease in the pH so that it is more compatible with our tissues. Now let's move on and talk about indications. An drug indication, we're talking about why it is being prescribed. Why is the drug indicated for the patient? All right, and there's a variety of wizardry that goes along with determining which drug gets prescribed. Now, this is definitely out of our scope, but just for your information, it could be according to the patient's current medical condition, the circumstances of the patient, and or the known therapeutic effect of the drug. All right, so we're also going to take into consideration, or the healthcare provider, the effect of the pharmacokinetics and pharmacodynamics of the drug as well. Contraindications are the opposite of indications. If a drug is indicated, that means it's a good idea that we give the drug. But if the drug is contraindicated, that means there are reasons why we should not give it. All right? So determinations, again, are going to be made according to medical conditions, circumstances of the patient, the therapeutic effects, side effects, and adverse effects of the drug, as well as the toxic effects of the drug. And so an easy example to kind of wrap our brains around when we're talking about contraindications is with the drug aspirin. So what are some contraindications for taking aspirin? Well, the first one that jumps to my mind that could be a contraindication for any drug is if there is an allergy. And that's why it's so important when we are getting ready to open our sterile supplies that we verify if there are any allergies and what those allergies are. If the patient has a latex allergy, then the use of latex products would be contraindicated. Specifically talking about aspirin, another contraindication could be if the patient is on blood thinners, because aspirin also has a tendency to thin the blood. And then lastly, we want to avoid giving aspirin to children because it can cause a syndrome called Reye's syndrome. Now, the side effects of a drug are complications that we expect to occur when given a drug. Now, they're usually not happy, warm, fuzzy things that are happening. They are undesirable, but they are usually mild, right? Some examples could include a rash, stomach upset, vomiting, constipation, diarrhea, dry mouth, dizziness, drowsiness, etc., etc. If you've ever, been watching TV and there's some ad that comes on for a pharmaceutical product, it seems like the list of side effects are much longer than the list of things that the drug is going to help us with. So having said that, suffice it to say that when they do their drug trials, if one person had if one person had bloody stool from taking the medication out of 1 million people that took it, it's still going to be listed as a side effect, and they're required to list that. I just did a quick little search regarding Tylenol and what some side effects could potentially be from Tylenol. And some of the things I found was black tarry stool, cloudy or bloody urine, pain in the lower back or side, skin rash, ulcers, decreased urine output, and unexpected bleeding or bruising. Now, adverse effects are a little bit different than side effects. Adverse effects are more serious and they can cause harm to the patient, and that could potentially include death, could include anaphylaxis, hair loss, which is alopecia, bone marrow depression, and damage to vital organs as well. So the toxic effects of a drug are usually related to overdosing. However, that isn't always the case. A toxic effect could also be seen when metabolism of the drug or excretion of the drug are impeded, right? So toxicity level is studied carefully during the development of the drug, and the effects are typically known. Now let's go back to thinking about our patients that have certain conditions. The elderly is one thing that jumps to mind for me, because as we age, our organs don't function like they used to, right? And so that could also lead to an increase in toxic effects. And those are things that need to be taken into consideration when healthcare professionals are determining what is the best course of treatment for the patient. Teratogenic effects are those that cause malformations and can cause damage to the embryo or the fetus and result in birth defects. Aside from drugs are not the only culprit that can cause birth defects. Other agents that might interfere are viruses and radiation, as well as a variety of other factors as well. So there are 5 different categories of drug classifications specific to pregnant women. The FDA is the agency that is responsible for drug safety, and so they developed this classification system as it relates to pregnant women to reduce the potential of birth defects or congenital defects. So there's categories A, B, C, and D, and then there is category X. Category A is safe to use during pregnancy. There is no risk associated with those types of drugs whatsoever. Category B is determined through human studies that there's no risk to human embryos or fetus, but there were some associated with animal studies. So they determined that there could be a slight risk for use during pregnancy. Category C, again, there's been human studies, but not a lot of them, or they are lacking, and maybe there's only been animal studies that have shown adverse effects of a drug, and so the determination is that category C drugs carry a risk, but the potential benefits could outweigh the risk. Category D, similar. Benefits could outweigh the risks, but only in life-threatening situations. And then lastly, category X, under no circumstances is it indicated that pregnant women should have these categories of drugs, and they are contraindicated in all situations regardless. When we use the term iatrogenic, what we mean is that there's a complication that was caused inadvertently due to the healthcare provider or as a result of medical treatment. This doesn't always have to do with drugs, and a common example is a healthcare acquired infection or nosocomial infection can be considered an iatrogenic response. And so aside from nosocomial infections, could also include side effects, adverse effects, toxic effects, and teratogenic effects as well. When an individual develops a tolerance to a drug, that means they now have a decreased response to the same dose. I know for me in the past, I used to take 2 ibuprofen if I had a headache, and 200 milligram ibuprofen were enough to do the trick. That was 20 years ago. Now I take 3 ibuprofen instead, and in the future might have to take 4 ibuprofen to get the same effects from the ibuprofen. And so this is just a very simple example of tolerance, but it can be applied in any situation where drugs are being used. And there's 3 different types of tolerance. And the first one is referred to as metabolic tolerance, which means the drug is being metabolized more rapidly. And the second one is cellular tolerance. And this makes me think of the word insensitivity, like the receptors on the cell have become insensitive to the drug. Kind of makes me think of type 2 diabetes as well, with insulin becoming the cells becoming insulin resistant, right? And then the last one is behavioral tolerance, which is where the individual learns to conceal the effects of the drug, which again it is less physiological than it is psychological. And kind of staying in that same vein, addiction is characterized as a disease, and addiction just doesn't apply here when we're talking about pharmaceuticals. It could pretty much be to anything. It could be to gambling, it could be to food, it could be to smoking, any of those things. But here, when we're specifically talking about pharmaceuticals, addiction results when a drug is needed for normal function, quote unquote. Now, that may be a physiological need, but it can also be a psychological need, and the two can exist simultaneously as well. And like I said, it's seen in a variety of cases. It could be narcotics, it could be alcohol, it could be benzos, it could be opioids, cigarettes, gambling, shopping, food, any of those things could an individual could become addicted to. And the book gives a website that individuals can access if they need help. That help is readily available for individuals. And lastly, we'll just touch on withdrawal. And withdrawal, which is also sometimes referred to as detoxification, occurs when someone that is addicted discontinues the use of whatever they're addicted to. When we're talking about pharmaceuticals, this could be as much physical as it is psychological. When the individual starts to experience symptoms, and it really, those symptoms vary in severity person to person. Some common symptoms are listed here for you: nausea, vomiting, diarrhea, constipation, sweating, tremors. And then sometimes something that happens is called a rebound effect. And a rebound effect is where whatever problem was being treated by the drug kind of comes back with a vengeance in the beginning. until homeostasis is achieved in the body. So that concludes our lecture on pharmacodynamics. Remember, pharmacodynamics is the way that a drug interacts with the body, specifically target receptors, cell membranes, the cell, the tissue, organs, and the whole body. So I hope this lecture was helpful and it contributed to your understanding. Thank you for listening.